Dr. Coleman, Dr. Chamberlain, ladies and gentlemen, first I would like to thank the organizing committee to invite me here and share with you our recent work on clinical implications of gene alterations in risk-adapted treatment of AML. As we know, acute myeloid leukemia is a heterogeneous group of diseases with great variability in the pathogenesis, clinical course, and the response to treatment. Treatment according to risk factors of individual patient may not only improve the prognosis, but also reduce the toxicity from therapy. The main risk factors in AML are age, white blood cell count, genetic alterations, including chromosomal abnormalities and molecular gene mutations not detectable by chromosome analysis. The clinical implications of recurrent chromosomal abnormalities are well known, but that for molecular gene mutations is not completely understood. So in this talk, I will focus on the clinical implication of molecular gene mutations. About half of AML patients have chromosomal abnormalities that you are well known. For the half of patients, they don't have any chromosomal abnormality, so-called cnAML, cytogenetically normal AML. But with molecular techniques, most of them have gene mutations. In our study, the most common gene mutations in cnAML patients is NPM1 mutation, around 38%, followed by FLT3 internal tandem duplication, ITD, around 31%. The two mutations frequently occur in the same patient concurrently. CBPA mutation is also common, around 23%. Only a small part of patients do not have any genetic alterations. Some of these gene mutations, such as FLT3, internal tandem duplication, tyrosine kinase domain mutation, KIT, NRAS, and KRAS mutations, involve signal transduction pathway and confirm cell proliferation and survival. They are categorized as class 1 mutations. Class 2 mutations, such as 821, 1517 translocations, inversion 16, 11q23 translocation, MLL partial tandem duplication, CBPA and RUNX1 mutations involve the transcription factors or cofactors and impair cell differentiation. It is suggested the development of AML requires the cooperation of class 1 and class 2 mutations. The roles of WT1 and NPM1 mutations, the clear pathogenesis of these two mutations are not quite clear yet, but WT1 mutation behaves more like class 1 mutation and NPM1 mutation like a class 2 mutation. In addition to genetic change, epigenetic regulation also play an important role in the pathogenesis of AML, such as DNA methylation, histone methylation, and acetylation. Recently, gene mutations related to epigenetic modification, such as IDH1, IDH2, AXS01, TET2, and DMT3A mutations were detected in AML. They can be considered as class 3 mutations. The roles of some class 1 and class 2 mutations in the leukemogenesis of AML are shown in this figure. Class 1 mutation involved receptor tyrosine kinase, such as FLT3, KIT, or signal pathway, such as RAS, PTPN11. Class 1 mutation confers cell proliferation. On the other side, Class 2 mutations involved transcription factors or cofactors, such as 821, 15, 17 translocations, inversion 16, 11q23 translocation leading to MLL fusion, and MLL partial tandem duplication, PTD, CBPA, and RUNX1 mutations, and confer impairing cell differentiation. Nuclear phosmin NPM1 is a chaperone protein shuttling between nucleus and the cytoplasm. In NPM1 mutation, the protein accumulated in cytoplasm instead of the nucleus. They usually located in normal condition. Class 3 mutations related to epigenetic deregulation. In cells, DNA wraps around histone protein and forms nucleosome core unit. Epigenetic modification involved DNA methylation, histone acetylation, and methylation. If a gene promoter CpG island is unmethylated, and the histone lysine residue K acetylated, and H3K4, the activation mark, methylated, the chromatin is open and the transcription is on. But when the the gene promoter CpG island is methylated through DNA methyltransferase, histone deacetylated through histone deacetylase, and the H3K9 or K27, the inactivation mark, methylated through histone methyltransferase, the chromatin is tight and the transcription is off. Through this epigenetic modification, the gene expression is regulated. The class 3 mutations involve the gene related to this epigenetic modification, such as DMT3A, TET2, IDH1-2, ASSL1 mutations. DMT3A is a DNA methyltransferase. TET2 can catalyze conversion of 5-methylcytosine to 5-hydroxymethylcytosine, so it's involved in DNA demethylation. IDH1 and IDH2 mutations result in decrease of alpha-ketoglutarate, a coenzyme of TET2. ASSL1 is a polyclone group protein, possibly involved in histone methylation. The instance of gene mutation in total cohort of AML in our study is shown in this figure. FRIS3 ITD and NPM1 mutations are the two most common mutations, around 20%. Class 1 NRAS mutation, Class 2 CBPA and RUNX1 mutations, and Class 3 DNMT3A, TET2, IDH2, ASSL1 also common. In patients with normal karyotype, the instance of those mutations closely related to normal karyotype gets higher, around 38% for NPM1 mutation and 31% for FRIS3 ITD in this normal karyotype patient, and CBPA around 23%. As compared with the reports from other centers, we have higher instance of CBPA and RUNX1 mutation, but lower instance of NPM1 mutation. FRIS3 internal tandem duplication is similar. The interaction of genetic alterations in AML is shown in this figure. Each color represents one mutation, and each column represents the mutation pattern of each patient. Compatible with two-hit theory, it's common to see two or more mutations occur in the same patient. usually one class 1 and one class 2 mutation, and sometimes combine one class 3 mutation. There are close associations between specific mutations, such as NPM1 mutation with FLT3-ITD and FLT3-TKD, and DMT3A mutations. 821 translocation associated with KIT mutation, 1517 mutation associated with FLT3-ITD and FLT3-TKD, and inversion 16 with NRAS mutation, and etc. Some of these mutations can predict prognosis. It's well known that patients with CEBPA mutation, especially double mutation, that is mutations in both alleles, and the mutation of NPM1 but without FLT3-ITD, can predict longer survival than other patients. They are good risk genotype. We have similar findings. Patients with CEBPA double mutation and the NPM1 mutation without FLT3-ITD have better survival. In a large cohort analysis according to cytogenetic and molecular abnormalities from MRC, Medical Research Council, United Kingdom, it showed that good risk genotype, NPM1 mutation, and CEBPA biallelic mutation without FLT3-ITD have favorable outcome as those with co-binding factor leukemia, that is T821 and inversion 16. On the contrary, patients with FLT3-ITD but without NPM1 mutation have very short survival as those with poor risk cytogenetics. The clinical implications of other gene mutations are not so clear, but emerging evidences show that several other gene mutations can also predict prognosis, as shown in this figure. Patients with DNMT3A mutations had shorter survival than other patients without the mutation, both in total cohort and in CM-AML patients less than 60 years. It is a poor risk genotype. RUNX1 mutation and WT1 mutations also are poor risk genotypes. Patients with these two gene mutations have shorter survival than other patients. In order to find out independent prognostic factor, multivariate analysis was performed, including traditional risk factors, age, white blood cell count, karyotype, and gene mutations related to prognosis. It shows that NPM1 mutation without FLT3-ITD and the CEBPA double mutation are independent good prognosis factor, while older age, higher white count, poor risk karyotype, WT1, DMT3A, RUNX1 mutations are poor independent poor risk factors. A scoring system incorporating all these risk factors into survival analysis are shown in this figure. The factors associated with good prognosis are scored -1, and those with poor prognosis are scored +1. The final score of each patient is the sum of all scores. With this scoring system, AML patients can be separated into 5 groups with different prognosis. To make it simple, AML patients can be separated into 3 risk groups according to cytogenetic and molecular risk factors. Patients with 821, 15, 17 translocation inversion 16, and CBPA NPM1 mutations without FLT3 ITD are good risk patients. But in patients with co-binding factor AML, that is with T821 and inversion 16, the presence of KIT mutation predicted shorter survival. Patients with FLT3 ITD without NPM1 mutation, RUNX1, WT1, DNMT3A mutations, poor risk cytogenetics, MLL partial tendon duplication are poor risk patient, or others intermediate risk. It has been shown that patients with good risk genotype respond well to high-dose post-remission chemotherapy alone. So, allogeneic hematopoietic stem cell transplantation is not necessary in first complete remission. But for poor-risk genotype patient, HSCT is indicated. As shown this German-Austrian AML study, patients with good risk genotype NPM1 mutation without FLT3 ITD did not get benefit from allogeneic hematopoietic stem cell transplantation. No survival difference in between patients with donor, so most of them receive allo-HSCT, and those without donor, so they did not receive allo-HSCT. But in patients with poor risk genotype, allo-HSCT did improve their survival. It is suggested patients with good risk genotypes need not receive allo-HSCT in first complete remission. The benefit of allo-HSCT in patients with RUNX1 mutation is shown in this figure. Patients with RUNX1 mutation have shorter survival than others without this mutation if not receiving allo-HSCT. But they have similar or even a trend of better survival than patients without this mutation, probably due to GVL effect. So it is suggested patients with poor risk genotype receive allo-HSCT in first complete remission. Similar findings are shown by German-Austrian AML study group. RUNX1 mutation patients had shorter survival, but allo-HSCT improved their survival. In addition to predict prognosis, gene mutation can be used as biomarkers to monitor minimum residual disease, MRD. NPM1 mutation is a good example. We monitored NPM1 mutant in NPM1 mutated patients and found that less than 2 logs reduction of NPM1 mutant after consolidation chemotherapy have shorter overall survival and relapse-free survival. So more aggressive treatment may be needed for this group of patients. German-Austrian AML study group analyzed a larger group of patients and found patients with positive MRD after induction chemotherapy or after completion of therapy have higher relapse rate and shorter survival. These genetic alterations can be targets of treatment. For receptor tyrosine kinase such as FLT3, there are FLT3 inhibitors. For signaling pathway, there's a farnesyltransferase inhibitor, tipifarnib. It can inhibit farnesylation of RAS, which is necessary for RAS activation. For transcription factor PML-RARA fusion, there are all-trans retinoic acid arsenic trioxide. For epigenetic modification, there are DNA demethylating agents and histone deacetylase inhibitor. It has been shown patients with TET2 or DMT3A mutation, the two mutations related to epigenetic deregulation, respond better to demethylating agent. For summary, most AML patients have genetic aberrations and usually with 2 or more hits. Genetic abnormalities can predict clinical outcome. Gene alterations can be used as therapeutic targets as well as biomarkers to monitor minimal residual disease. Risk-adapted treatment according to genotype at diagnosis and MRD after treatment may improve the clinical outcome of patients while reduce the side effects of treatment. Finally, I will thank my teachers and colleagues in the laboratory and the Department of Hematology, National Taiwan University Hospital. Thank you for your attention.